This presentation is brought to you by Fertility Connected regarding the assessment and treatment for people with fertility problems. This information is put together for the public by the National Institute for Health and Clinical Excellence. You may be asking yourself whether this information applies to you. It applies to you if you need particular treatment or help for you or your partner to get pregnant, including if you are unable to or find it very difficult to have sexual intercourse, for example due to a physical disability. It also applies to you if you have fertility problems, that is, you or your partner having trouble getting pregnant. It applies to you if you need particular treatment or help for you or your partner to get pregnant, including if you are in a same-sex relationship and have not been able to conceive through donor insemination. You may also need treatment if you or your partner have a condition that means you need specific help to conceive. This may include long-term viral infections such as HIV, hepatitis B, or hepatitis C that could be passed on through unprotected sexual intercourse. Also, if you're preparing for cancer treatment that might affect your fertility and you wish to preserve your fertility. So let's begin by giving a little bit of background information about fertility problems. So around 1 in 7 heterosexual couples in the UK seek advice at some time in their lives about difficulties in getting pregnant. The time it takes to conceive naturally varies, and age can be an important factor. Both women's and, to a lesser extent, men's fertility gradually declines as they get older. In men, a fertility problem is usually because of low numbers or poor quality of sperm. For up to a quarter of people, no reason can be found for their fertility problems. This is known as unexplained infertility. When it comes to your care team, a range of professionals who specialize in different areas of treatment or support may be involved in your care. These could include GPs, practice nurses, fertility specialists, and counselors that all work together for the betterment of your fertility health. Some treatments or care described here may not be suitable for you. If you think that your treatment does not match this advice, talk to your care team. So, how long does it take to get pregnant? In the general population, more than 8 out of 10 couples where the woman is aged under 40 will get pregnant within 1 year if they have regular sexual intercourse. So in this case, regular sexual intercourse equates to around every 2 to 3 days without the use of contraception. More than 9 out of 10 couples will get pregnant within 2 years. For women under 40 who are using artificial insemination rather than sexual intercourse to conceive, more than half of women will get pregnant within 6 cycles of intrauterine insemination. And within 12 cycles, more than 3 out of 4 women will become pregnant. Luckily, if you are one of those people that are struggling with conception, there may be things that you can do to improve your chances of getting pregnant. Your GP should tell you more about the following. So how often should you have sexual intercourse? To give yourselves the best chance of success, try to have sexual intercourse every 2 to 3 days. If you are under psychological stress, it can affect your relationship and is likely to reduce your sex drive. And if this means you do not have sex as often as usual, this may also affect you or your partner's chances of getting pregnant. So let's discuss smoking and its detrimental effects it has on your fertility. So smoking is likely to reduce fertility in women, as well as passive smoking, which is breathing in someone else's cigarette smoke. If you do smoke, your GP should offer you help to stop if you wish. The NHS Smoking Helpline can also provide advice and support, and the phone number to contact the NHS Smoking Helpline is 0300 123 1044, and the website is www.smokefree.nhs.uk. When it comes to men, there is a link between smoking and poorer semen quality, and through the effect of this on fertility is uncertain, however. Stopping smoking will improve your general health for sure. For men, your fertility is unlikely to be affected if your alcohol consumption is within the recommended limit of 3 to 4 units of alcohol per day. A pint of normal strength beer is about 2 units, and a small glass of wine is about 1.5 units for reference. Drinking excessive amounts of alcohol can affect semen quality. When it comes to the link between alcohol and women's fertility, in women, alcohol can harm developing babies. If you're trying to get pregnant, you can cut down the risk of harming your unborn baby by drinking no more than 1 or 2 units of alcohol once or twice a week. So you may already be taking medicines and drugs related to conditions that you currently have, but it's important to note that some prescriptions and over-the-counter medicines can in fact interfere with your fertility. Your GP should ask you about any medicines that you're taking and offer you appropriate advice whether to continue or stop taking these medications. They should also ask you about recreational drugs such as cannabis, cocaine, and anabolic steroid use, as these can also interfere with your fertility and damage a developing baby. So there are a few other lifestyle factors that are linked to fertility. Other actions that people try to improve their fertility with include reducing their caffeine intake and using complementary therapies. However, it's not clear that there is an association between caffeine intake and fertility, and complementary therapies are not generally recommended because there's not been enough research looking at whether they do improve fertility. When it comes to men, they also try to wear loose-fitting underwear to help with fertility. Where higher temperatures in the scrotum can reduce semen quality, it's not really clear whether wearing loose-fitting underwear improves fertility, so it's not recommended by your practitioner per se. So folic acid is something that's prescribed for women who are trying to get pregnant at about 0.4 milligrams per day. By taking folic acid when you're trying for a baby and for the first 12 weeks of pregnancy, you reduce the risks of having a baby with neural tube defects, where parts of the brain or spinal cord do not form properly, and this can lead to things like spina bifida. If you have previously had a child with neural tube defects or are taking medication for epilepsy or have diabetes, this dose is usually increased to 5 milligrams per day. Rubella is the German measles. Women should be offered a test to find out whether you are immune to rubella. If you're not immune to rubella, you should have a rubella vaccination before you try to become pregnant, because infection with rubella can harm unborn babies. You should avoid pregnancy for 1 month after your rubella vaccination. When it comes to cervical smear tests, your GP should ask when your last one was and what the result was. If a cervical smear test is due, you should have this test before you try to get pregnant. And overall, if you're concerned about your fertility, your GP should ask you about your lifestyle, general health, and medical history. They should also ask how long you and your partner have been trying to get pregnant and about aspects of your sexual health and history that could be affecting your chances of having a baby. If you and your partner have been trying to get pregnant for more than 1 year, you should both be offered tests to see the underlying problem. And if you're using artificial insemination rather than sexual intercourse to conceive and you are not pregnant after 6 cycles, you should be offered these tests. If you are having artificial insemination using your partner's sperm, your partner should also be offered tests. You should be offered early referral for specialist advice and tests if any of the following apply to you, including if the woman is aged 36 years or over, if there is a known medical reason for your fertility problems, for example, if you've had cancer treatment in the past, and if that has affected your fertility or you have a condition or problem that may have affected your fertility. If you or your partner has a long-term viral infection, including HIV, hepatitis B or hepatitis C, that could be passed to your partner through unprotected sexual intercourse or passed to your baby, you should be referred to a centre that has the expertise to provide your investigations and treatment safely. You could also see HIV, hepatitis B and hepatitis C for more information. For couples who want to have a baby but are unable to or find it very difficult to have sexual intercourse, your GP should talk to you about your options for conceiving and advise you on any further assessments you might need and possible treatments that could help you. So now let's move on to fertility investigations, which are very important in the fertility process of overcoming infertility. So during your care and treatment, your healthcare team should give you information, including written information, about fertility problems and treatments to help you make informed decisions about your care. Any investigations of your fertility problems should take place in an environment that enables you to discuss sensitive issues such as sexual abuse if you wish to. If you and your partner are having difficulty conceiving, any decisions you make about investigations and treatments will affect both of you. Therefore, you should both be seen together whenever possible to discuss your fertility. If you are diagnosed with a fertility problem, you should be treated by a specialist team. You should also be given information about appropriate support groups, which you may find helpful to contact. So let's talk about counselling when it comes to support groups. So you should have the opportunity to see a counsellor before, during and after any tests and treatments you have, regardless of whether the treatment is successful. The counsellor should be someone who is not directly involved in managing your treatment. They should talk over and help you think about what your fertility problems and treatments will mean for you. Fertility problems, investigations, and treatments can be stressful, so it can help to discuss with someone your feelings about the future, whether or not your treatment enables you to have a baby. So tests for men are part of the fertility investigations that can be performed, and that should be performed actually. You should be offered a semen test to measure the quantity and quality of your sperm. Occasionally there is an abnormal result on the first semen test. If this does happen, a repeat test should be offered, ideally 3 months later. However, if it looks as though your sperm count is very low or you have no sperm at all, the test should be repeated as soon as possible. When it comes to tests for women, a woman's fertility declines with age. This means that the chances of getting pregnant, both naturally and through fertility treatment, falls as you get older, inevitably. Your GP should give you more information about this. Your GP should also ask how often and how regular your periods are. If you have regular monthly periods, which is every 26 to 36 days, you are likely to be ovulating. However, you should not be advised to use charts of your body temperature, known as the basal body temperature, to check whether you're ovulating normally, as they are not a reliable test for ovulation. When it comes to checking your hormone levels, you should be offered blood tests to see if you're ovulating, to check your hormone levels, and these may include a test to measure a hormone called progesterone, which is produced by the ovaries after the egg is released. The timing of this test will vary depending on how regular your periods are. If your periods are irregular, you should also be offered a test to measure hormones called gonadotrophins, which stimulate the ovaries to produce eggs. Check your ovaries. You may also be offered tests to see how well your ovaries might respond to fertility drugs. This involves either a blood test to measure levels of hormones called follicle-stimulating hormone and anti-Mullerian hormone, or an ultrasound scan to count the number of follicles in your ovaries. Also check your fallopian tubes. When the results of your tests and your partner's semen tests are known, you may also be offered an examination to see whether your fallopian tubes are blocked. Depending on your circumstances and medical history, this might be done using an X-ray, ultrasound, or by an operation called a laparoscopy. Before you have this procedure, you should be tested for an infection called chlamydia. So chlamydia can damage your fallopian tubes if it is diagnosed, and can be treated with antibiotics. If you are infected, you and your partner or partners should be referred for treatment as soon as possible. If you do not have tests for chlamydia, you may be offered antibiotics before the procedure as a precaution in case you do have the infection. You should not normally be offered the following tests because they have not been shown to be helpful, including tests of your cervical mucus after sexual intercourse, known as the postcoital test, or a blood test to measure levels of a hormone called prolactin. You should not normally be offered the following tests because they have not been shown to be helpful, and these tests include a biopsy, which is essentially a procedure to take a small sample of tissue of the lining of your womb. And you shouldn't be offered an examination of your womb called a hysteroscopy. In some circumstances, your doctor may need to perform a hysteroscopy, but it will be carried out as a part of your laparoscopy procedure. If you are unable to ejaculate, there are treatments that may help you and so improve your fertility. Alternatively, you may be offered surgical sperm recovery and IVF. For men who have low levels of gonadotrophins, these are the hormones that stimulate the production of sperm, you should be offered treatment with gonadotrophin drugs to help improve your fertility overall. There are a few treatments that should not be offered under routine procedure. There is not enough evidence that any of the following treatments can improve fertility, including surgery for varicose veins in the scrotum, these are known as varicoceles, and also antibiotic treatments for white blood cells in your semen. Steroids for anti-sperm antibodies, as well as treatments with gonadotrophins or other fertility drugs for problems with sperm that have no known cause, come under treatments that should not be offered, as there's not enough evidence to prove that they improve fertility. So let's move on to treatments for women. If your ovaries are not producing eggs normally, you should be offered treatment to stimulate them to produce eggs. This is known as ovulation induction. The type of treatments you need will depend on what is causing the problem. Polycystic ovary syndrome, otherwise known as PCOS, is a common condition where your ovaries contain more eggs than normal, but you do not ovulate regularly. If you have polycystic ovary syndrome and you are obese, which means that your BMI is 30 or above, losing weight may restart ovulation and increase your chances of becoming pregnant without needing any further treatment. If you do need to take fertility drugs, losing weight will improve how your ovaries respond to these drugs. So if you do have polycystic ovary syndrome, you should be offered drugs called clomiphene citrate or metformin to help you start ovulating. You may be offered one of these drugs on its own or both together in combination. If you are taking clomiphene citrate, you should take it for a maximum of 6 months to see whether it will help you. If you're offered treatment with metformin, your doctor should explain that it can cause side effects, such as nausea, vomiting, or other digestive symptoms. When it comes to clomiphene citrate and metformin, they don't work for everyone. If they do not help, you may be offered treatment with gonadotrophins. However, your doctor should explain the increased risk of multiple pregnancy and ovarian hyperstimulation syndrome before you decide to start this treatment. An alternative treatment for polycystic ovary syndrome is called laparoscopic ovarian drilling. This is a surgical procedure that involves a general anesthetic and a laparoscopy. This can work just as well as treatment with gonadotrophins, but does not need monitoring by ultrasound and does not increase your risk of multiple pregnancy. Your doctor should tell you more about the risks, benefits, and side effects of all of these treatments for polycystic ovary syndrome and methods of ovulation induction before you decide to try them. So as mentioned before, there are risks of fertility drugs. So multiple pregnancy is one of the risks. Ovulation induction using gonadotrophins or clomiphene citrate increases your chance of becoming pregnant with more than one baby. And this is what a multiple pregnancy means. So the thing is, multiple pregnancies carry greater health risks for you and your babies. The babies are more likely to be premature and have low birth weight. To reduce the risk of multiple pregnancy, your response to these drugs should be monitored by ultrasound during the treatment. Another risk that comes with fertility drugs is ovarian hyperstimulation syndrome. There is a risk that your ovaries could overreact to fertility drugs, otherwise known as ovarian hyperstimulation syndrome. The mild symptoms of this include bloating and nausea, which are relatively common, but severe ovarian hyperstimulation syndrome can be a serious condition. You should be monitored by ultrasound for this condition during your ovulation induction. Of course, there has been discussion around the long-term safety of ovulation induction. Currently, there are no known health risks, including cancer risks, directly associated with the use of fertility drugs for ovulation induction in women or in the children born as a result of treatment. However, more research is needed into the long-term safety. Your doctor should give you up-to-date safety information before you start the treatment. They should also limit the drugs used in ovulation induction to the lowest effective dose and the length of use to minimize the risks. Other ovulation disorders, if you have an ovulation disorder with low levels of gonadotrophin hormones and you have low levels of estrogen, this is often due to low body weight or excessive amounts of exercise. Increasing your body weight, if your BMI is less than 19, and cutting down your exercise may be enough to restart ovulation and therefore improve your fertility. To help you ovulate, you may be offered gonadotrophins or a treatment called pulsatile gonadotrophin releasing hormone, in which a drug is given gradually through a pump to mimic the natural delivery of gonadotrophins within the body. If you have a disorder called hyperprolactinemia, you should be offered treatment with a type of drug known as dopamine agonists, such as bromocriptine. Your doctor should discuss with you the safety of dopamine agonists for women who are intending to get pregnant. So what if your fallopian tubes are blocked? If you have blocked fallopian tubes, you may be offered surgery to correct it if the blockage is not severe. If your fallopian tubes are blocked and swollen, and a condition known as hydrosalpinx, you should be offered the choice to having your tubes removed through laparoscopy before the IVF procedure. This increases your chance of a successful pregnancy through IVF, but it means that you'll never be able to conceive naturally in the future.